So what we're going to do today is we're going to do psych. So the very first psych condition we're going to talk about is depression. So first of all, what does it mean to be depressed? This is a question that you're supposed to answer. Okay, so a loss of pleasure and decrease in feeling. So the word depressed means to push down. And what we're typically talking about is a feeling of not feeling as well. So if you think of a person's kind of like emotional state and you graph that through time, you're going to push that downwards and you're going to keep it downwards. Now, there are specific criteria for what constitutes depression. And it's not just I feel bad, but it's a person feels low for a certain amount of time. It has to be extended through time. And then there's typically some other features that we go along with that. So you guys are going to have to learn some of those features for this class. We're going to call it SIGI caps. So each letter stands for the first letter of a word that is associated with it. So the first one is sleep. And we're going to ask the person if they've had any changes in their sleep. Do they sleep more than usual or less than usual? Now, which of those do you think is probably more common with depression? More. A person just doesn't feel like getting out of bed. But some people have atypical depression where they have the opposite and they can't sleep. Another thing to consider is that a person can have unipolar depression, which is where they go down and back up to baseline. Or the person can have bipolar depression. So they can feel depressed, but then swing back the other direction. Patients with bipolar depression are much more likely to have that atypical pattern where they can't sleep. So it's not just you feel like sleeping more than usual, it's have there been any changes in your sleep? Do you have any problems sleeping, more or less than usual? The next one is interest in things that you ordinarily enjoy. So the fancy schmancy word here is anhedonia, which means loss of pleasure. So a lot of times people will say that they just, like maybe they like going out to the movies, maybe they like talking with their friends, maybe they like going shopping. They're like, I just am not interested in what I'm usually interested in. Does that make sense? The next one is feelings of guilt or worthlessness. Some of you right now are going, me. You sound like the seagull from Finding Nemo. Me. All right, the next one is energy. Do you feel like you have more energy or less energy than usual? And which way does depression typically go? Less. Bipolar depression can go more than usual. So you don't ask just one direction, we ask both directions. Next one is concentration. Have you felt like you've been having trouble concentrating? Me. The next one is appetite. Now, this one can go both directions. Typical depression is a person doesn't feel like eating, and that goes along with interest in things you enjoy. Most people enjoy eating, and so when they lose the enjoyment of everything, they lose the enjoyment of food, and they stop eating, just don't have an appetite. Other people, on the other hand, will eat more than usual. So you kind of like, you eat your feelings is what it's sometimes called. In terms of maintaining what many of us would consider a nice weight, you're like, why can't I just be the depression where you don't eat anything? But there's problems with both of those. Neither one of them is healthy. So anyway, appetite. And then the next one is psychosomatic. There's another term for this as well, but it's basically when you're depressed, do you move less than usual or more than usual? Do you have symptoms that occur that come on with your feelings? So when a person is depressed, they might not move at all. They're like, I could go all day and not do anything. That would be depressed psychosomatic. On the other hand, when some people are depressed, they move more than usual. That would be more likely to be bipolar. And then the last one is suicidal and homicidal ideations. So do you think about killing yourself and or other people? Now, if a person says yes, and by the way, you do ask just like that. Do you think about killing yourself or killing someone else? Yeah, you try it. All the time. Yeah. Okay. What's interesting is that depressed people don't have enough, they already feel guilty about it. They don't have enough energy to lie. They'll just tell you, yes. So then what's the follow-up question? Do you have a plan? And then, yes, what is the plan? And hopefully they're not telling you how they're going to kill you. But anyway. Most people who are depressed are not homicidal, but there are enough of them that have been spectacularly so that we have to ask this as well. But most of the time, if they want to hurt themselves, they don't want to hurt other people. So these collectively are called SIGI caps. On a patient who you suspect of depression, you need to ask these questions. Now, everyone you see in the hospital is at risk for depression. And it's not just the doctor's job to screen for depression. It is every member of the healthcare team's job to screen for depression. So don't just assume, oh, you're young, you're not depressed. I know people who have graduated from this program who have been depressed all 4 years that they were in this program. They came in as freshmen depressed. They tried to commit suicide 2 or 3 times while they're in the program. They graduate. They're still depressed. So just because a person is young does not mean that they're not at risk for depression. If they're in the hospital, they're at risk for depression, and you need to be asking. Does that make sense? And I can tell you, one of the things we're going to start doing this year in FYE is we're actually going to start educating little freshmen on this whole SIGI caps thing and trying to get them some help so that they don't have to go all 4 years being depressed. So anyway, SIGI caps, any questions? All right, so when it comes to treating depression, one of the things that we want to make sure is that we are not just treating transient feelings. So one of the major reasons why people often feel depressed is because of a loss. So we call that bereavement. So how can you tell normal bereavement from depression? I think you're supposed to be on the next slide over. Yeah. Yeah. So how can you tell depression from normal bereavement? Okay, one is it goes away. Well, what time frame should it go away in? So typically within 3 months. Now that might be a long time to be sad, but it's within 3 months. What else? If the reason you're depressed is sad is because of bereavement, how would you separate that from depression? Think about your SIGI caps things. What would you probably not have if you're just sad that your grandfather died or your mother died? Okay, you might not have suicidal ideations, and what would you probably not have unless you're the one who killed her? Guilt. So those excessive feelings of guilt are one of the big hallmarks of, is it depression versus is it just bereavement? Sure, having some feelings of guilt, but not overwhelming feelings of guilt, and certainly not of being worthless. The guilt is specific. I should have spent more time with them. I wish I would have said this before they died. Not, I'm a horrible person and I'm worthless. Does that make sense? Okay. Now, as far as treatments go, it's one of these things where drugs are a part of the treatment, but they cannot be the exclusive treatment. And unfortunately, in today's healthcare environment, there's just not enough time to really treat people appropriately. And so a lot of times, drugs are the only things that a person gets, if they get anything at all. And that's not how it's supposed to be. So some of the therapies that we use for depression, the first one is called cognitive behavioral therapy, or CBT. What do you think cognitive is? Thinking. So you think about things differently. What's the main way that cognitive therapy takes place, do you think? Say it? Okay, well, with cognitive behavioral therapy, so. Talking, counseling. So you talk about your feelings, you talk about what's going on in your life, and you think about what's going on, you reflect. Now, one of the reasons why this can be helpful is when was the last time someone really listened to you? How many people do you think have no one in their lives who really listens to them? And so when you go to a therapist whose job it is to do nothing but listen to you for a whole hour, how do you think you might feel at the end of that? I feel a little bit better. And if you're allowed to process things and bounce ideas off someone and work through your problems without them judging you all the time, how many have ever gone to someone for help? And the first thing they do is, well, that's stupid. What's that going to do to your ability to process through your thoughts now? Gone. I'm never talking to you again about my feelings. So one of the reasons why cognitive therapy can be so helpful is because for some people, the only time they ever really get to talk about their feelings or work through things without being judged or shut down is during that therapy session. What is behavioral therapy? Doing something. Tell me some things we can do. Exercise, painting or art, music, pets. Yeah, I'm going to include yoga in exercise. Yeah, meditation. Okay, fine. But so you're doing something. If you had me for FYE, one of the things I always talk about is if you want to be, you have to do. And a lot of times when we do something, that precipitates a change into being. And so you feel like you're too tired to get up and get out of bed, and you have no energy, but you do it anyway, and then you begin to feel a little bit better. One of the problems with depression, and when you don't feel like doing anything, is that how many of you ever had a few days off where you didn't ever get dressed, and you might not have had a shower, and you didn't do your hair or put on makeup, whatever it is girls do, to look like real people, and you just stayed in your room all day, and after 2 or 3 days of that, you didn't really feel like you could do anything. Now, so one of the problems with being depressed is that when you indulge that feeling, it produces itself more and more. So by getting up at a normal time, doing your hair, grooming yourself, putting on real clothes, going and doing something, even if it's just going to the cafeteria to eat breakfast, makes you feel like you're a more normal person than if you just sat around in your pajamas all day in bed. Does that make sense? Okay. So that's part of the behavioral therapy. One of the other therapies we need to mention is called ECT, Electroconvulsive Therapy. Basically, they put electrodes up against your head and run electricity through your brain. Shocking, I know. So, in electroconvulsive therapy, it used to be considered barbaric because when you do that, it induces seizures in the patient. They would break their teeth. They would have incredible soreness afterwards because every muscle in their body is completely contracted. So the way that we do it nowadays is we put them under anesthesia, then we shock their brain, and when they come out of it, it's like their brain feels better, but their body hasn't been destroyed in the process. So for whatever reason, for some patients, electroconvulsive therapy is very, very helpful for them. I guess kind of like, when your computer is not doing well, what's the first thing you do? You shut it down and turn it back on. Kind of like reset. So it's kind of like hitting a reset button to some degree. So for some people, it doesn't help at all, and for some people, they think it's the best thing they've ever done.
Does it like reset?
No, you're not. No.
No. So if you have a hormone imbalance.
Right. Right. So yeah. But anyway, for whatever reason, it seems to help some people. That's it. We don't know why particularly, but the reason a person is depressed is because of certain neurological patterns. And whatever the electroconvulsive therapy does, it disrupts those patterns and helps them to feel better. It's something that they typically will have on a regular basis, maybe once a week or even once a month, depending. So if you ever hear someone talk about how barbaric it was, yeah, before we used general anesthesia, it was. Now, not so much. So. Well, you have to have a healthy heart, I guess. Yeah, make and bank. So, all right. So anyway, that is some of the alternative, or not alternative, but non-drug therapies that we can use for depression. Now, when it comes to the drugs, we're going to go kind of like in the order, more or less, that they were invented for a while anyway. So the very oldest drugs that we have are tricyclic antidepressants, TCAs. TCAs are very, very old drugs, and they work in more than one way. So the mechanism of action is uncertain. However, we do know that they work on norepinephrine. So they upregulate norepinephrine, and we think that's probably the way that they actually help a person be better. These are the kind of drug that I once heard a psychiatrist describe as the kind of drug you want your mother-in-law to be on. So it might help you, but it's going to make you miserable along the way. And the reason for that is that they have a lot of adverse effects because they work in so many different ways. So some of them have adverse effects that will cause a person to be more sleepy than usual, while another one will cause a person to be less sleepy than usual. So you typically, what you do when you choose them is you kind of prescribe the adverse effect. So if a person is having depression where they can't get out of bed, you give them a drug that has insomnia as an adverse effect. And if a person, all they want to do is, the person can't sleep, then you give them one of the drugs that has, drowsiness as an adverse effect. Does that make sense? So you're basically prescribing kind of the opposite of what their symptomatology are. Now, just in general, with all of these depression drugs, the theory is if you can get a person to high enough a dose for long enough a time, all of them will be equally effective. Now, it's not exactly true in practice, but that's the theory. So what's the theory? If you can get them high enough a dose, long enough a time, they'll all be effective. Now, the reason why tricyclic antidepressants are typically not effective is it's really hard to get them to high enough a dose for long enough a time, because the adverse effects will make them miserable, and they'll go off the drug. Yes, ma'am?
You said it was upregulation of norepinephrine?
Yes. So the patient has more norepinephrine in their brain. Whatever.
So which one is it?
Norepinephrine. Just say that.
There's no norepinephrine.
Yeah. So, tricyclic antidepressants. The three you need to know. The first one is amitriptyline. Or Elavil. That's probably the most common one, and it's very commonly used in elderly patients at low doses for insomnia. So the problem with a lot of the sleeping medications that we normally use for patients who have trouble sleeping is that it will make them wake up in the middle of the night confused. So when you use them on an elderly patient who's already confused, and they get even more confused at night, and now they're waking up in the middle of the night, it's not very fun. So what you would prefer is a drug like this instead. These are also used as adjunct to pain management. So a lot of times the patients have neurological pain. You can use this at a low dose for that. If a person has restless leg syndrome, you can use it for that. So they're usually not used for depression anymore because it's hard to get the patient to high enough a dose. But you use them for these other weird neurological things. The other one is nortriptyline, which is spelled the same. And then the last one is imipramine. Imipramine. And that's called tofradil. So those are the three that you need to memorize. No, the normal sleeping pills are not good to give to elderly patients. So you give them one of these drugs at a low dose. So it's not high enough a dose to be an antidepressant, but it's high enough a dose to make them drowsy. But they won't wake up in the middle of the night confused. They might wake up, but it won't make them confused the way that the other sleeping drugs will. All right, any questions about tricyclic antidepressants? If you see a patient on it, chances are they're not on it for depression. What are they on it for? Some other neurological thing. If they're only taking it 50 milligrams at night, amitriptyline, what are they on it for? Insomnia. All right, the next drug class that we're going to use or talk about is MAO inhibitors. So what do you remember about MAO inhibitors from Pathopharm 1? I don't remember nothing. So monoamine oxidase is an enzyme, and what does it do? Breaks down epinephrine and dopamine, and epinephrine, norepinephrine, and dopamine. So MAO inhibitors are going to inhibit the breakdown of norepinephrine and dopamine. It's going to raise their levels in the brain, making the person feel better. What's the main problem with the MAO inhibitors? Say again? Interactions with, all right, with some pathomimetics and tyramine-containing foods. Now, as it turns out, a lot of the other psych drugs also work on norepinephrine or dopamine or serotonin. And there's some overlap among serotonin and norepinephrine receptor activity. As a result, you can only give MAO inhibitors by themselves. You can't mix them with any of the other drugs. And you need what's called a 2-week washout period before you start another drug. So if you say, look, I know you've been on this MAO inhibitor for a long time, and we're going to take you off of it. We're going to put you on an SSRI instead. You've got a no drug for 2 weeks, then you start the new drug. Does that make sense? What's the reason for that? To keep the patient from dying from norepinephrine toxicity. So the drug names you need to know there are Nardil and Marplan. Those are brand names because I can never remember the generics of them. What? No. Linezolid is an antibiotic that has MAO inhibition adverse effects, but it's not actually an MAO inhibitor. So the MAO inhibitor that we are going to learn for this class, Nardil and Marplan. Those are brand names. I can't remember the generics offhand, so I guess you don't have to either. Write it down on the board. Nardil and Marplan. All right, any questions about MAO inhibitors? They can be effective, but there's a lot of limitations to using them, so you're rarely going to see them be used for this purpose. Anyway, the next drugs, the very first drugs that were really effective, and the very first one of these drugs became the #1 prescribed drug in the United States back in the 80s, is the selective serotonin reuptake inhibitors, SSRIs. So, SSRIs work by inhibiting the reuptake of serotonin. Gosh, just like the name says. But what does that actually do? Well, there's more serotonin in the brain then. So the question is depression caused by a loss of serotonin? And the answer is no. Nope. Now, here's an interesting thing. We're going to have to talk about lobsters for a minute. Lobsters have a serotonin system very similar to ours. You know how a lobster gets more serotonin? It wins a fight. You know how it gets low serotonin? It loses a fight. What's interesting is if you give an SSRI to a lobster that lost a fight, guess what it'll do? It'll pretend like it won. So a lobster that loses is like little, makes itself small and unintimidating. And if you give an SSRI, then it gets big, like, hey, I'm a big lobster again. Pretty interesting, huh? So the theory is that we as humans use serotonin to kind of find our place in the pecking order of things. So for men, what's the pecking order determined by? You have no idea because... All right, let me ask you this. How many of you would consider dating a guy you thought was a loser? Would you just, you know what? I like losers. I want to date a loser. Or you want to date a guy who you think is good at something. Now, maybe your parents think he's a loser, but what did you see in him? Potential. Okay. So, but there's some way that you have in your brain that ranks men, right, in a hierarchy. This guy is better than that guy's better than this guy. I guess if I had to, I could date that guy, but you're ranking them in your head, right? You're also ranking yourself against other women, right? We're not going to ask about that. That's a way different thing. Yeah. Now, what happens if you're actually a very competent person? You're well educated, you've got good family, you've got good kids, you're doing well at your job, you make a lot of money, but you feel like none of it matters and you feel you're worthless. SSRIs are a really great choice for a person in that situation. Now, let's say that the reason you're depressed is because your life is falling apart because you're making horrible decisions for yourself. SSRIs are probably not going to help you. Does that make sense? So when the problem is that you are not ranking yourself accurately as to where you should be, SSRIs are probably a good fit. When the problem is your life is terrible because you're making terrible choices, well, SSRIs are not going to help with that. In fact, they might actually hurt because of some of the adverse effects we'll talk about. So SSRIs take at least 2 weeks before they start to work. And they typically are not going to you won't notice that they're working until about 4 weeks. And then the effect will continue to get stronger over time. You have to start them slow, lower dose, and then raise them up over time. And the reason for that is very early on, there's a potentially deadly adverse effect called serotonin syndrome. Remember I said there's some overlap between serotonin and norepinephrine? So when you first take SSRIs, sometimes it causes your brain to dump all of its serotonin at once. And then that excess serotonin starts to activate norepinephrine receptors, and the patient basically dies of too much sympathetic response. What do you think the signs and symptoms of serotonin syndrome would be if it's too much sympathetic response? High heart rate, high blood pressure, sweatiness, nervousness. Say that again, I can't really hear you. Okay, dilated pupils. Say it. Nausea. All right. Yeah. So it looks kind of like sympathetic response, except you add in seizures and high temperature. But high heart rate, high blood pressure, tremor, nausea, dilated eyes, all of those are sympathetic symptoms, right? Remember that? Pathopharm 1? No, I don't think I ever took Pathopharm 1. Okay. So when is the danger of that serotonin syndrome occurring the highest? In the first 3 days, also known as the first 72 hours. Wait a minute. 74 divided by 3. How did you do that in your head? Want to know how? Okay, so what's 25 times 3? 75. Subtract 3 out of that. Subtract 3 out of that. 72. There you go. 24 times 3 is that. Whoa. That is like Common Core math on steroids. Okay, so anyway, within the first 3 days, the first 72 hours, the risk of serotonin syndrome is the greatest. And so that's why you start them at a low dose. And then typically after about 2 weeks, you raise the dose up after the risk of serotonin syndrome is over. Now, the number one adverse effect in terms of affecting the most number of people with SSRIs is weight gain. So we have serotonin syndrome, and then we have weight gain. What causes the weight gain? Well, it's not eating your feelings so much as it's just increased eating in general. Now, part of this goes back to another adverse effect, which is increased impulsivity. Serotonin can make a person more impulsive. You know, if you feel like you're on top of the world, what do you feel like the results of your actions are? You can do anything. It's like a teenager, you know, I can do anything. As you get older, you get a little more cautious. Now, if you're relatively low on the hierarchy, you're going to be a little bit more careful about the things you do and say because you might be judged. You know, like think about a popular kid in high school. They could probably say or do anything. Everyone's like, oh, that's cool. But you know, the dorky kid, they do the same thing and they get hazed, right? So you're going to be a little more careful the lower down you are in the serotonin. So high serotonin levels can result in increased impulsivity, which in turn, when it comes to eating, can make a person gain weight. So it's not exclusively that, but it's basically increased appetite is the reason for weight gain. So how can a person prevent the weight gain? All right, meal planning, tracking your macros, increased exercise, all of those will help. The next most common adverse effect is decreased sexual pleasure. And this is not just for men, it's for women too. So it can be manifested as decreased libido. What's libido? Sex drive. So I just don't feel like it. But a person might have an intact sex drive, but nothing happens. And that's the number one reason why women go off of SSRIs. Another thing that can happen is a patient just feels flat. So when they were depressed, they would be sad, and then they'd be a little happy, and then they would be sad, but at least occasionally they were happy. Whereas now they just feel like this. I'm not really sad, but I'm not really happy either. So I just feel flat. Blank. Another complaint that people often have, especially at the beginning, is vivid dreams. Like disturbingly vivid dreams. Now, we've got to talk about kids and suicide, and also homicide. Almost all of the people that you read about who commit these school shootings are on SSRIs. Is it the SSRIs that are making them kill people? No, but the increased impulsivity helps. Now, if you take a look at teen suicide, patients who are depressed usually don't commit suicide because they're too depressed. That was the theory. That they have loss of energy, but they feel like killing themselves. You put them on an SSRI, and the theory was their energy came back before they felt better. And so now they have enough energy to carry out their plan. But that's not really what happens. What really happens is they just have increased impulsivity. And so it's that increased impulsivity that allows them to carry out plans they otherwise wouldn't have. Now, how many of you, go ahead.
So then, but eventually they start to feel better, right?
Yeah.
So would the suicide rate be highest like in the beginning?
It is highest in the beginning, but it's the increased impulsivity is what's driving it, not the energy coming back first.
Oh.
Now, how many of you have ever gone to a place like maybe the Grand Canyon or a tall building, and you look out and you're like, I wonder what it would be like to just... And then you have this thought, I'm stepping back. Now, some of you, that thought never crossed your mind. For others of you, the thought crossed your mind, and it scared you enough you took a step back. If you're on a drug that increases impulsivity, you might just find out. That makes sense? So that's kind of the idea that we're talking about. It's very common for people to have thoughts that cross their brain that are not good thoughts. I cannot pick up a pair of like, what do you call them, pruners, without wondering what it would be like to cut off my own hand, no, my own finger. Guess what? I've used pruners hundreds of times. I have all 10 fingers. All 5 fingers! I have no fingers on the other hand. I ran out of them. Yeah. But you get the idea. Just because you have a thought doesn't mean you have to act on it. However, with SSRIs, people are more likely to act out on those thoughts because of the increased impulsivity. So that is where the main danger comes from in terms of committing suicide or committing homicide. Now, depression does not make a person homicidal. That's a little bit outside the scope of this course. If you want, we can talk about that another time. A person would already be homicidal, and then being on drugs that increase their impulsivity make them more likely to carry that out. But it's not, being depressed does not make a person homicidal. All right, so these are the main adverse effects. We talked about this teen suicide, and the last thing we need to talk about is withdrawal syndrome. So when you stop these drugs, patients will go into withdrawal. That just SSRIs. They're all similar to that degree. Some will have worse or less depending on the patient. They all are metabolized a little bit differently, so some of it depends on your unique genetic profile of your CYP450 cytochrome P450 microzymal inside system. There you go. So,
relatively all.
Yes, but relatively they all have the potential for it. Okay. So when you go off these drugs, you'll have withdrawal syndrome. That's supposed to be a W, in case you're wondering. And that withdrawal syndrome is important. You tell patients do not go cold turkey off of your SSRI. So if you're on Prozac or sertraline or whatever, you need to taper the drug down, then go off the drug. And don't do it mid-semester. We're in a room full of young girls, some of whom are depressed, some of whom are taking SSRIs right now. And mid-semester, you're like, you know what? Can't have that. I got to go off this drug today. You go into withdrawal syndrome, you feel like crap, you can't think, you can't concentrate, and the next thing you know, you failed your next 2 tests. Don't do that. So, first of all, you don't go cold turkey, you taper. Second of all, don't do it mid-semester of nursing school. Can we all agree to that? Not me, I would never do that.
How long do the effects last after you?
The withdrawal syndrome usually lasts for a week to 2 weeks. And it depends how long you've been on it. Oh, well, yeah. You can look up the actual symptoms, but one of the things that also happens is that there seems to be a suppression of emotion while you're on SSRIs. Remember we talked about feeling flat? So let's say that, for example, that a person's father dies right here. Father dies. And the person says, I couldn't even cry at his funeral. They stay on SSRIs, and a year later, they say, you know what? I want to go off the SSRI. All these things that happened during that time, they begin to experience those emotions now. So that's another thing, is even though the withdrawal syndrome itself might be relatively short, you're dealing with the emotional impact of these things that occurred during that time. And so you're feeling all of these overwhelming emotions at once. And it's not bad. I mean, you have to experience them in order to get to the other side. But doing that mid-semester is probably not a good idea. Yeah, right before finals. So those are some of the big things that you need to know about SSRIs. Now, as far as drug names go, the very first drug that was discovered is fluoxetine, which is Prozac. And then there's sertraline, which is Zoloft. Then there's citalopram, which I'm not going to write down. That one is called Celexa. There's a newer version of it, S-citalopram. What do you mean? What do you think that is? Well, it is Lexapro, but it's the left hand. S for the sinister side, the left-hand version of citalopram. So remember that drugs come in racemic mixtures where you've got kind of a left molecule and a right molecule in the same drug. If you take away all of the right ones, you end up with an S. And if you take away all the left ones, you end up with a D. So D-glucose dextrose. In this case, S-citalopram, the left citalopram. And that's Lexapro. And there's a couple others, but those are the big ones. Paroxetine or Paxil, that was very popular for a while. Sometimes they're really popular as long as a drug company is marketing them heavily, but they were never really that good a drug. So as soon as it goes off patent and the drug company stops marketing it so aggressively, everyone kind of stops using it. Because let's face it, Paxil was not a very good drug, but it had really good marketing by Pfizer. All right, so we'll talk a little bit about those when we get there. So the question was, why do they use these for these other things like OCD and social anxiety? So SSRIs can be used not just for depression, but they can also be used for anxiety. They can be used for obsessive compulsive disorder and post-traumatic stress disorder and a number of other things as well. So sometimes we don't know exactly why it works, but we know that it works. So I'd say it's probably more of that. Whatever drugs are on your list. Yeah. So just like with Pathopharm 1, the drugs that are on your list are the ones you need to know.
Are you updating the PowerPoint? Or are they just
We'll talk later. Okay. All right. Any questions about SSRIs? Yes, ma'am. All right, so let's imagine for a moment that you started off at a 50 milligram dose of whatever imaginary drug we're going to give you. So then after 2 weeks, we raise your dose to 100. And then that wasn't enough, so after a month, we raised it up to 125. And then after 6 months, that wasn't enough, so we raised you up to 150. So you're not just going to go from 150 to 0. You're going to go from 150 to maybe 100 for a month, and then for 2 weeks at 100, and then another month at 20 or 50, and then go off the drug. Does that make sense? Okay. Yeah, that's just an example. No, sorry, one last thing. One of the big dangers of SSRIs and bipolar is that it can cycle a patient from depression into mania. So typically, how long does it take before a patient feels better on an SSRI? Yeah, so minimum 4 weeks most of the time. If you got a patient who's like, I feel better after like 2 or 3 days, bipolar. So we got the wrong diagnosis. You need to come back in, stop taking the SSRI. Yeah, we got to do something different. All right, the next drug class we're going to talk about is SNRIs. So in this case, what does the S stand for? Serotonin. What does the N stand for? Norepinephrine. So these are not selective. These are non-selective. And it's going to hit both serotonin and norepinephrine. So the two of those raising together has an increased risk for what problem? Serotonin syndrome. Yeah, so there's a potential for serotonin syndrome a little bit higher than SSRIs because you're affecting both at the same time. And they typically are going to cause potentially some anxiety issues. What's interesting is that you can also use them to treat anxiety. When you're anxious, how do you feel? A little shaky, maybe heart rate's going a little bit of sweat down the back, what are all those signs and symptoms of? Sympathetic. What mediates the sympathetic response? Norepinephrine. So norepinephrine in a person who tends to feel those things anyway can make them feel anxious. Now what's interesting is that you can use SNRIs to treat anxiety as well. So it might make you anxious, but it might treat your anxiety too. You just don't know. Yes, it is. So the question was, isn't Cymbalta always on commercials? And yes. A lot of these drugs are heavily marketed during, on TV. So if you actually watch TV and not Netflix, you'll be seeing an enormous number of these drugs being advertised to you. So SNRIs are very similar to SSRIs in a lot of ways, with that increased risk for anxiety, slightly increased risk for serotonin syndrome, but they don't have as much weight gain. In fact, in some patients, they actually lose weight. When I worked in Gainesville, there was a psychiatrist who was prescribing one of the SNRIs with the next drug we're about to talk about together for her and her daughter so they could lose weight because it kind of suppresses appetite. Not exactly on label, but I don't know. Who are we to judge what other doctors do for themselves and their daughters? Anyway, so that's what it is. Same thing, you want to start low dose, raise it up. The whole thing takes about 4 weeks. All that is still the same. And you don't want to discontinue suddenly. You want to taper. So drug names there. What is it? Say again? Yeah, duloxetine. I'm going to spell it wrong. Yeah, so this one is Cymbalta, and the other one is venlafaxine. So venlafaxine is Effexor, and then that one is actually a prodrug. And what it metabolizes into is called desvenlafaxine, which in turn is another drug whose name is escaping me at the moment. So duloxetine and desvenlafaxine are probably the ones you need to know the most. I don't think that venlafaxine by itself is really prescribed as often anymore. Right. Yeah, and it can help you, it can prevent you from sleeping. So you want to take it in the morning, not at night. All right. So this is the last of the true class drugs that we're going to talk about. The rest are kind of like more by themselves. That's not to say that there's not always a drug that works similarly, but for the most part, they're going to act by themselves. So the first drug we're going to talk about is Wellbutrin or bupropion. Bupropion is a dopamine reuptake inhibitor. It upregulates the amount of dopamine in your brain, and that in turn makes you feel good. We talked a little bit about dopamine in Pathopharm 1 when we talked about addiction. So when we are in pursuit of a goal and we're making progress, our brain rewards us with dopamine. And when we stop making progress towards that goal, we stop getting the dopamine. So if you've ever had this happen to you where you're working on a project and everything's working out and everything's going great and you're like, I feel great. And then you get a phone call and like the whole thing doesn't work anymore. How do you feel? Like defeated. Like, let's say that you were working on a school project and everything was coming together and you got your little team together and everything had their little thing. You're beginning to do things, oh, this is really cool, I like it. And then Someone says, hey, the teacher said we can't do that topic. I'm just not going to do any topic. Life sucks. This is so stupid. That loss of dopamine makes you feel not like you just don't want to do that anymore, but you don't want to do anything anymore. So increasing dopamine levels in the brain can make a person feel like they have meaning again. The other thing that it does is it causes slight excitation. So if you take it at night before you go to bed, you might have trouble sleeping, so you want to take it earlier in the day. Bupropion is usually sustained release nowadays, but you still have to take it twice a day. So you want to take the second dose typically no later than 4 o'clock in the afternoon. So 1 dose in the morning and 1 dose in the early afternoon. I was going to say there. It can help with concentration. So sometimes it's used off-label for patients with ADD or ADHD. There's no sexual side effects with it. So people like it for that. And there's no weight gain with it. And in fact, it might have a slightly weight or appetite suppressing effect. In addition to being used as an antidepressant, it's also used to help with addictions, in particular with stopping smoking. So with the addiction model that we talked about, every time you engage in the addictive behavior, you get rewarded with dopamine. And if your dopamine levels are already a little high, the amount of dopamine that you get doesn't seem as much. So it makes it less compelling to do the addictive behavior. Does that make sense? So what you would typically do is you start the bupropion for 2 weeks before your stop date, and then you stop. And the idea is that it will reduce the cravings and desire to do that thing. Any questions about bupropion? Is one good? It's usually 2 times per day. Are you taking it only once a day? Are you taking SR? It depends on how effective. If it's effective, then whatever. If it's not effective, then it can go to twice a day. So. You do the drug for 2 weeks, then you stop the addictive behavior. So you set your stop date for I'm going to stop smoking on whatever date. Start taking the bupropion 2 weeks before that. The last thing we need to mention is that it has the potential to decrease the seizure threshold, which means increased risk for seizures. So we don't give it to kids lower than 18, younger than 18. Any questions about bupropion? I mean, in the grand scheme of things, if I were going to choose an antidepressant drug for me to be on, that's the one I'd say, start me with that. But that's just me. All right. The next one we have is a drug called trazodone. It's a very old drug. So now we're kind of going backwards. So it's a very old drug, and it's not a very good antidepressant, but it can make a person drowsy. So a lot of times you'll see patients on it, especially elderly patients, who are on it to help them sleep. Any questions about that? Oh, one of the adverse effects is called priapism, which is an erection that lasts for more than 4 hours. So before we had Viagra, you could use that and hope. But it wasn't very effective. So the main use for trazodone, 50 milligrams before bedtime as a sleep aid in elderly patients. All right, next we have a drug called mirtazapine. And the brand name is Remeron. This is sometimes called a tetracyclic antidepressant, but there's no class of tetracyclics. It's just a drug that's sometimes called that. And it's a very interesting drug in that the main adverse effect is drowsiness. I mean, incredible drowsiness. Like all they want to do is sleep all day, drowsiness. But the longer you're on it, the less the drowsiness affects a person. So it actually affects them the most when they first start the drug, when they're on low doses of it. As you increase the dose, the drowsiness begins to fade away. Does that make sense? Is there any drug that I'm supposed to talk about that I'm missing in the antidepressants? Nifazodil? Cerazone. Oh, yeah. I can't remember what I'm supposed to say about that one. There you go. All right. Nifazodil, Cerazone, multiple adverse effects. Any questions? Yeah. It works in different ways, so we're not really sure which of them is the therapeutic one, but maybe it's all of them at the same time. All right. On that note, we're done with depression. How do you feel? Depressed? To be honest, I'm a little depressed right now. Oh, yeah. So atypical antipsychotics, I just need to mention that those are most often used to treat bipolar depression. They're also used to treat depression with psychotic features. So I guess we'll talk about those in just a minute. So in your notes, I believe the next thing we're supposed to talk about is anxiety. Is that correct? Or yes, I know. I just mentioned them. Yeah. So after that, what's the next thing in your notes? Okay. So the next thing then is sedative hypnotics. And the first sedative hypnotic is the benzodiazepines, or benzos for short. Doctors are very lazy people, and they don't like to pronounce that many syllables. So benzodiazepines become benzos.
So is this for depression or for?
Well, these are kind of, it's not for depression. We're done with depression. So just, yes. So what did I say about atypical antidepressants? Sorry. What did I say about atypical antipsychotics? So we use them for bipolar depression, and we use them for depression with psychotic features, which we will talk about later. So we will come back to those later. But I just want you to be aware that we use those in depression patients. We're going to talk about them in detail later. All right. So the next topic now is we're going to talk about drugs that can be used for some multi-purpose things, and then we'll talk about their use for different things, if that makes sense. So benzodiazepines. Okay, all benzos work on GABA receptors. So they bind to the receptor, and then they upregulate it. What does that mean? They make it more sensitive. So it's going to work harder than usual. Now, GABA is always inhibitory. So what we're doing is we're inhibiting central nervous function. And that's going to result in a couple different effects. So one of the effects of GABA upregulation is decreased anxiety. Feel calmer. So we can use these as anxiolytics. A patient feels really anxious, you give them one of these drugs, and it mellows them out. That could be for an anxiety attack, or it could be before surgery. You know, if you're going to induce anesthesia, you want them a little calm. And what do people tend to be before surgery anyway? Nervous. So helps calm them down. So decreases anxiety, reduces breathing, reduces respiratory rate. If you're going to stop their breathing so that you can, put them on the heart-lung machine for anesthesia, that might be helpful. Most of the time, this is potentially deadly, though. No, this effect. Now, the nice thing is, when it comes to respiratory depression, benzos by themselves do not have the ability to make you stop breathing. But if you combine them with other central nervous system depressants, they do have the potential to stop breathing. So tell me some other central nervous system depressants. Alcohol. What's the number one thing people take their Xanax with? Alcohol, wine. Not necessarily the best idea. What about Benadryl? Oh, yeah. What about opioids? Yeah. Huh. Now, what I want you to do is look up Heath Ledger toxicity. What was he on at the time he died? He was on a benzodiazepine. He was on an I don't think it was Benadryl, but he was on an antihistamine, and I think he was on an opioid. All like normal doses. He didn't overdose. But the combination of those three things together stopped him breathing. So, he was partying too much and overdosed. Nope. He was on prescribed medications, but the combination of those three drugs together stopped his breathing. So, you got to be careful when you're dealing with benzodiazepines. But by themselves, they're inherently safe when it comes to stopping breathing until you combine them with other things. So, first one is anxiety, the decreased respirations, decreased muscle contraction. They act as muscle relaxants. They also inhibit the formation of new memories. So we call that Anterograde Amnesia. They make a person drowsy, so it can be used as a sleep aid. And they decrease seizure activity, so we can use them to treat seizures. Whew, that's kind of a lot of stuff, isn't it? Yeah. Okay. What is anterograde amnesia? You don't make new memories. So what would that make these drugs really useful for? Surgery. Because you give them the drug and then they don't remember the surgery. What else would it be useful for if you're not a good person? Taking advantage of unsuspecting people. So date rape drugs are almost always benzodiazepines. They're usually benzodiazepines that are not approved for human use. So they're used for like horses or cats and dogs. Horses are really big animals. I don't know if you know this or not. So you give a human a horse dose, and is it any wonder that they're a little loopy? And you mix it in their drink, because they're drinking at the same time. They don't remember nothing. What's it called when you're drinking and you can't remember what happened? Blackout. So anterograde amnesia is basically a blackout. So Rufinol, Roofies, is a benzodiazepine, approved for use in horses. Yeah. So the muscle contraction, we use these as muscle relaxants. A lot of times, like someone say in a car accident and their muscles are all stiff the next day, you can use benzodiazepines for that. We can use them as a sleep aid. So one of the drugs, temazepam, its brand name is Restoril. I wonder what you use that for. Yeah. And then we can use them to treat seizures that are in progress. So if the patient has a seizure, you can give them IV push benzodiazepine to stop the seizure. There's also a very long-acting benzodiazepine that we can use to prevent seizures. So we'll talk all about the individual drugs in a minute or two. There's a little table in your book that has a list of a bunch of different benzos and what they're used for. You need to know that table for the drugs on your list. So, drug names you need to know. Let's start with everyone's favorite, diazepam. Also known as Valium. This was the first one that was like really popular. Before Prozac, it was the #1 prescribed drug in the United States. How many have ever seen the movie Beetlejuice? There's a moment where they try and scare the mother, and Winona Ryder's character says, "She can't hear you. She's sleeping with Prince Valium tonight." she'd taken Valium, so she wasn't going to be scared of nothing because she wasn't waking up. Yeah. Yeah, that was the idea. But just a funny little pun. So anyway, diazepam is used as a sleep aid. It's used as an anti-anxiety medication. It's used to stop seizures in progress. I think I said muscle, or used as a muscle relaxant. It can be used for a lot of different things. The next one that's also kind of multi-use like that is lorazepam. This one is more commonly used nowadays than Valium, just because it lasts a little bit longer and it's more predictable in its pharmacokinetics. So it's basically a better version of diazepam. The next one we have is alprazolam. And that one is Xanax. And it's used exclusively for anxiety. It's pretty long acting. So if you take it, it's going to last all day long. In patients who have never had it before, it can last the next 2 days. Just don't feel quite right yet. So diazepam, lorazepam, alprazolam, clonazepam is used only for seizures. It is a very long-acting one, and it's used to prevent seizures, not to treat seizures in progress. So if a patient has a seizure in progress, which are the two drugs that you want to use? Diazepam or lorazepam. The next drug we've got is temazepam. And the drug name is the brand name is Restoril, and that is going to be used as a sleep aid. Now, what kind of patients should not use Restoril as a sleep aid? Elderly patients. Why not elderly? Because if they wake up, they're going to be confused. So we don't want to use benzodiazepines in elderly patients if we can avoid it. Let's see, this 1, 2, 3, 4, 5. And number 6 is midazolam. And the brand name is Versed. So this is a very, 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 very short-acting drug. You give it IV only, and it's pretty much gone in 20 minutes. Its half-life is 5 minutes. So it's very often used before surgeries. Now, nurses can push Versed just fine. When you combine Versed along with an opioid, you get something called conscious sedation. Sometimes it's called twilight. So the patient is still alert. They can still follow directions, but they don't really remember what happened afterwards. It used to be very common to use that for colonoscopies and some other procedures. So, conscious sedation is considered anesthesia. It is outside the scope of practice for an RN to give conscious sedation. So, sometimes, especially if you work in an ICU, it's like, hey, nurse, come on here. Okay. All right. I've started this IV with the opioid here, and here's the midazolam. So when I nod, you push a little bit of Versed, okay? Okay. You're outside your scope of practice. You're now practicing anesthesia. Don't do that. If something goes down and that patient goes south, it doesn't matter that the doctor said, hey, come over here and do this. Your license, your responsibility, you knew better. Does that make sense? Now, so what you say is, I'm sorry, Dr. So-and-so, that's outside my scope of practice, and I would love to help you, but I'm protecting us both. Well, I'll get a nurse who'll do it. Okay, it's fine.
But you can give it without an opioid.
Yes, you can give it by itself, but you can't give it while you're also pushing an opioid IV. You can't give the both of them at the same time, because that's the conscious sedation. You know, we always want to do cool things, and you always want to go a little bit above and beyond, but when you're taking that much risk, you can lose your license. say it's probably not worth it. Now, I know graduates who have done that, and they've confessed, and, I'm doing what you said not to do. I'm like, it's your license, not mine, so. Whatever. You're the nurse now. You got to live with yourself, not me. So, anyway, I know it's a lot to go with benzos, but there you go. Any questions? Oh, and there's one last one I need to mention, which is chlordiazepoxide. See if you can spell that one. I don't know if I can spell it. Its brand name is easy, Librium. And Librium, are you judging by my notes or by the book? Ha ha! Maybe you never know. Okay. So Librium, its main claim to fame is that it's got a very, very long half-life, and it's used primarily to prevent alcohol detox. So when a patient goes off alcohol, they're going to experience alcohol withdrawal, if you're talking about someone who's an addict. So earlier, the withdrawal has 3 distinct stages. The early withdrawal syndrome, which is basically just like some irritation and anxiety, then potential seizures, and then delirium tremens. So delirium tremens happen last, and they're life-threatening. Notice that the seizures are not life-threatening. You can use any of the benzodiazepines, really, well, the ones that are used for seizures, you can use those to prevent the seizures. You can also use them to prevent DTs. But you'll have to keep giving diazepam and lorazepam because their half-lives aren't long enough, whereas Librium's half-life is long enough to last the entire time. So anyway, I don't think Librium is on your test, but you will have a question about DTs. And I've given you a slide in your notes that conveniently has the time frames for each of those withdrawal parts. It might not be in the PowerPoint itself, but it's probably in the voice thread, now that I think about it. All right, well, there's a slide somewhere. We'll look for it. But you need to know that slide for your test. So you need to know the time frames. All right. Any other questions about benzos? Delirium tremens. One of the ways you can prevent delirium tremens is by giving the patient alcohol. And some hospitals will have like whiskey or other things like that, or vodka in their formulary. And you'll actually have like, shot of vodka to be given, POQD. Yeah. Because sometimes it's easier just to keep them on it than it is to deal with the DTs. So anyway, next we've got barbiturates. Okay, barbiturates act similarly to benzos in that they attach to GABA receptors, but instead of just upregulating the receptor, it also directly stimulates it. As a result of that, there's no ceiling to its effects. So remember that no matter how much benzo you give, eventually there's no more effect. So that makes them relatively safe. Barbiturates, there's no ceiling to the effect. You can keep giving it until you basically shut down the person's brain and they die of a coma. Now, most barbiturates, by the time they are effective at stopping seizures or anxiety, your patient's already asleep. There's really only a couple that are effective at alert doses. And the main one there, the number one that's used, is called phenobarbital. So phenobarbital is the one you need to know. It's commonly used in patients who have seizure disorder to reduce the risk of seizures or to treat a seizure that won't go away. Do you remember what it's called when an asthma attack won't go away even with treatment? Status asthmaticus. Well, what do you think a seizure is called that doesn't go away even with treatment? Status. What's the disease of having seizures? So status epilepticus. So the number one treatment for status epilepticus is diazepam, lorazepam. If those don't work and the patient's still in status epilepticus, then you put them into a barbiturate coma for 3 weeks. And then we bring them back out, see if they still have a seizure or not. So we'll learn more about that when we talk about seizures. Okay, next, sedative hypnotics. So then we have benzo-like drugs. And there's a couple of these. The very first one is zolpidem or Ambien. So it affects GABA receptors, but not quite the same. It doesn't have the same structure as a benzodiazepine. It's a little bit weaker. Oh, by the way, all of these are controlled substances. All the benzos, the barbiturates, and the benzo-likes, they're all controlled substances. Does that make sense? Okay. So zolpidem or Ambien works similarly to Restoril, except a few fewer side effects. Back when I was working as a nurse practitioner was when Ambien was still relatively new, and all of the Pfizer reps were on Ambien. They're like, it is the best sleep you've ever had. You've just never been that well rested in your life. So the way that you're supposed to take it is you've brushed your teeth, you've done your bedtime ritual, you're in your pajamas, you're next to your bed, you take the drug, you go to sleep. So a lot of us, the way we do things is we take the sleeping pill, then we play on our phones, then we get up and we get a snack, and then we go back and we, play on our phones some more, maybe watch some Netflix, and it doesn't work that way. So what you're supposed to do is you're ready to go to bed, you take the drug, go to bed. Does that make sense? Okay. So zolpidem. And then you've got some other drugs that are kind of similar but a little bit different. So Zaloplan is one. Is that Lunesta? Sonata. And then you've got another one that's Lunesta. What's Lunesta's brand name? Or generic, sorry. You don't have that one? All right. What do you? Sure. Yeah, it's like azaclopidine or something like that. Yeah. Anyway, there you go. Sonata is benzo-like. I don't think that Lunesta is a little bit different. Doesn't matter. And then we've got one last one, which is not benzo-like. That is called Rosarum. And this one is a melatonin activist or agonist. So melatonin is produced in the pineal gland in the back of your brain. And melatonin is responsible for what we call sleep cue. How many of you, around maybe 10:30 at night, you start, oh, so tired. I need to go to bed. Oh, shit. But you don't. And then 11:15 rolls around, and you're like, I'm not tired at all. I can stay up till 2. Okay. So that I feel so tired I should go to sleep is called a sleep cue. And melatonin is what's responsible for the sleep cue. When you fight through the sleep cue, it goes away. So when you're on a drug like Rosarum, it's not going to make you drowsy per se, but it's going to give you a sleep cue. Can you ignore your sleep cue? Yeah. So if you do, the drug ain't going to work. Does that make sense? Okay. So these drugs are particularly good for people who get messed up sleep-wake cycles, like AKA people who work shifts, night shift people. So anyway. Now, when it comes to treating sleep disorders, this is one of those cases where the drugs are as effective or sometimes more effective. The non-drug therapies are as effective, if not more, than drug therapies. So I've got a whole little, in the voice thread anyway, I don't know about the PowerPoint. I may not have updated that one yet. I've got a whole long list of non-pharmacological things you can do for sleep. So before you go out and start taking drugs to go to sleep, you should first do those behavioral things. A lot of them are really simple, and you need to try and do those things first. So I'm not going to go over all of them here in the class because they're on your voice thread. Or should I? I should. Okay. Since we're recording, why not? So the very first thing is what they call sleep hygiene. So don't hang out in your bed until it's time to sleep. You need to associate your bed with sleeping, not with hanging out and watching Netflix. It's kind of hard when you're in a tiny little dorm and the only place you can get away from people is your bedroom. But if you have a desk, sit in the desk instead. So that's the first thing. The second thing is keep a schedule. We are creatures of habit. You're going to get tired at the same time every day if you start going to bed at the same time every day. Does that make sense? So keep a schedule and try and maintain that. The third one is pay attention to your sleep cue. When you get it, go to sleep. Now the problem is when you get really messed up, you get your sleep cue at like 7:30 p.m. You're probably not really ready to go to bed at 7:30. So sometimes that's where the melatonin and that sort of stuff can come in helpful. Avoid blue light at night. So blue light is produced by the sun. When you go out in the sun in the morning and you get that nice light, and you're like so tired and groggy, you go out in the sun, you feel better, you feel like you should be awake. That's because in part of the blue light. So our phones and other devices tend to emit a lot of blue light. So what you notice on a lot of them nowadays is they have like a red filter or red shift. So what that does is as it gets to be nighttime, it turns the color of your screen more towards the red tones so that you don't have as much of that blue light awakeness. You can also use blue light blocking sunglasses or eyeglasses. That can help to reduce that as well. The other thing is you don't want your room to be too hot, so you want a cool room. You want the most comfortable bed you can afford. You're going to spend a third of your life in bed. You might as well have a really good bed. If you spent $5,000 on your bed and you kept it for 20 years, you'd probably sleep so much better that it's almost like you're a millionaire. Just saying. But $5,000, Dr. Heyman, I can get a bed for $300 and never sleep again. Choice is yours, just say it. You're going to be a nurse, especially if you're working nights where you're trying to sleep during the day, these things become even more important. So anyway, if you're coming home from a 12-hour shift and you're wanting to sleep during the day, wear sunglasses on your way home and then don't be on your phone afterward. Yeah, blackout shades is good. That works for both day and night. Earplugs can be helpful depending on your living situation. And, like if you're married and you're a person. Okay. Also, white noise source can be helpful. Your phone has a white noise app. You might have to download it, but you don't need to buy a special device for that. What else am I missing from that list? Oh, yeah. Alcohol can make you drowsy, but it also impairs the restfulness of your sleep. Also want to avoid caffeine. Caffeine lasts for about 5 hours, so you don't want to have caffeine for at least 6 hours before you go to bed. What else? Oh, yeah, too much exercise and also even like a shower. Sometimes the shower is very stimulating because you're getting hit by all these little water drops. So even though it might be relaxing, it could also impair your ability to go to sleep. So for some of you, a hot shower makes you go to sleep. For others, it prevents you from going to sleep. Learn your own body and do what you need to do. So avoiding exercise too late and also other stimulating things. All right. Netflix in bed. Just say no. Just one more episode. Oh my gosh, do you see what just happened? I'll just watch the next 5 minutes of the next episode and then I'll go to, do you see what, next thing you know it's 5 in the morning. Don't do that. And then you have to watch it again because you fell asleep during it. Yeah, anyway. Okay, anything else on my list there? All right, so yeah, before you go to bed, engage in some relaxation. So maybe that's different for everyone. Maybe it's some nice music, maybe some chamomile tea. I don't know, a little bit of milk helps some people. Stretch, do some meditation, but just something that helps to transition you from everything is crazy to, okay, now I'm calm and relaxed. And then I'm going to give you an herb name that you might want to look at called ashwagandha. This is an Indian herb. That's a W. So ashwagandha actually can act as an anxiolytic as well. If you're the kind of person where you try and go to sleep and you can't because the thoughts are running around in your head super fast, ashwagandha can be very helpful for that. And it can also be helpful for test anxiety. So I actually mentioned this in Pathopharm 1 on the test anxiety thing. So if you still haven't tried it yet, and you're that kind of person, it might help you. It really helps my wife in terms of like, she has trouble sleeping a lot of times. When she takes that, she just goes right to sleep. Any questions? What? Oh, the ashwagandha? No, well, I'm sure you can, but it's usually just a like a capsule. It's got the root inside it. You can get it online at Amazon or Walmart, of all places. I haven't seen it inside the store, but their website carries it. So. All right. Any other questions about insomnia there? I do need to mention that there's different types of insomnia. So one of the insomnias is you can't get to sleep. And that can be from a number of reasons. Some of them is like there's too many thoughts just running around in your head. Another type of insomnia is where you wake up in the middle of the night and you're still sleepy, but you just have a hard time sleeping. And then the hardest kind of insomnia to treat is called terminal insomnia, where you go to bed like normal and then you wake up at like 2 or 3 in the morning, done. Like you wake up like, okay, I'm ready to go. But it's still 2 or 3 in the morning. Yeah, you're not tired anymore. But then the rest of the day, you're really tired. One other thing I should mention is sleep apnea. If a person is sleeping, but they're not feeling refreshed afterwards, like they don't feel like they have energy to face the day, or if they're falling asleep during the day. For example, we had a student who, right there, I was teaching nursing research, and he asked this really great question. And so I started to answer him, and he would fall asleep during tests, and it turned out he had sleep apnea. So once he had to lose weight, and he had to get on the sleep apnea CPAP machine, but he started doing that, and all of a sudden it was like a different person, because he was falling asleep because he wasn't being refreshed at night because of the sleep apnea. So that's the last thing, is to be screened for sleep apnea. All right, any other questions about insomnia? Think we should take a break? All right, 2:30? Okay. On that note, let's keep going here. So, you have to have some silence in the video so you can figure out where things are. All right, so we're done with sleep. What we're going to talk about now is anxiety. So, for anxiety medications, you can use benzodiazepines for anxiety, but it's best for episodic anxiety. Because of the potentially addictive nature of them, they're not something you want to take every day. Also, because of the other adverse effects, they're something that you typically don't want to take every day as well. So if a person has panic attacks, or if they have situational anxiety, say I have anxiety when I go on an airplane, that's the sort of thing that benzodiazepines work really well for. For generalized anxiety, where you kind of feel anxious all the time, it's not quite as good a treatment. So say it again?
Like an anxiety attack?
Either an attack, a panic attack, or something that is situational, like test anxiety. The problem with taking benzos for test anxiety is that they can cause amnesia. But hey, you just don't remember the test. You don't forget the stuff you already learned. Whew. One of our 2009 graduates, it's kind of a while back, but she actually had the flu while she was taking the NCLEX, and she took the NCLEX while taking Xanax. So, and she passed first time. Who knew? Well, okay, I knew. But anyway, so it can be done, but not necessarily the best idea. So anyway, For episodic and for panic attacks, then benzos are kind of the preferred there. Because she also had test anxiety.
I thought it was for the flu.
No, not for the flu.
The way you said it didn't kind of make it sound like that.
Sorry, didn't mean that. She happened to have the flu. She also had test anxiety, and she took Xanax while she was taking the Inclex, while she also happened to have the flu, not because of the flu. Anyway, but she passed. So when it comes to test anxiety and other situational anxieties, you got to figure out what works for you. All right. So for generalized anxiety, which is different than situational only occurs in certain situations, or you're anxious about certain things. Generalized anxiety is kind of like a generally anxious about everything. You can still be anxious about certain things, but you don't need something to be anxious about. You're just kind of anxious all the time. So that's generalized anxiety. And for that, we typically want to use something like an SSRI or an SNRI are very commonly used for patients in that situation. Now, we have some related things like phobias, and you can use SSRIs for phobias as well. And then we have OCD, which is obsessive compulsive disorder. Now, obsessive compulsive disorder involves two things. One is an obsession. What's an obsession? It's a fixation, it's an idea, it's a thought that you obsess over. And then the obsession is related to a compulsion, which is a behavior that the person does, usually repetitively. They don't always match. So the common thing that people think of is you wash your hands because you're afraid of germs. But see, that's a logical connection, and most OCD is not a logical connection. So for example, I have a friend who's very mild OCD, but her OCD, her obsession is people dying of AIDS in Africa. So the compulsion is, like if she's out shopping, she has to touch every item until she doesn't think of people dying of AIDS in Africa, and then that's the one she can take. And that's the key to OCD. There is no logical relation between the obsession and the compulsion. Does that make sense? So the problem with OCD that a lot of patients have is they know that it doesn't make sense, but they still can't stop doing it. And then that makes them even more upset. So it's kind of like a downward spiral of, I know it doesn't help, but I can't stop doing it, and now I feel bad about doing it because I know it's making everyone else in my life crazy. Now, there's another disorder that's related, but very, very, very different, called OCPD, Obsessive Compulsive Personality Disorder. Now, SSRIs aren't necessarily used to treat this, but OCPD is where the person thinks that all of the things they do are the right way to do it, and everyone else is wrong. So OCPD people tend to be very perfectionistic, and no one else can ever live up to their perfection. So if you ever live with a person like this, you know that they're like, I don't know why anyone, I'm just trying to do it the right way. And everyone else is like pulling their hair out and doesn't want to be around them.
Can you pull it?
Sure, they're distinctly different things.
So I had like anxiety when I was in high school, like somewhat of OCD, and I wasn't on an SSRI, but I was on Lamotrigine.
Say it again.
Lamotrigine or Lamotrigine.
Yes.
But it says it's used for
And bipolar. It's called a mood stabilizer.
Yeah.
We'll talk about that later when we talk about bipolar. True Confessions Day. I don't know if you treat it with any particular drug, but I just want you to know that there's a difference between OCD and OCPD. So, because a lot of people have never heard of this one, because it's not, it's a personality disorder, not a psychiatric disorder. There's a distinction between them. You'll learn that when you get to psych. But there's just a difference between these two things. And this is what we think of as the obsessive compulsive disorder. This is a perfectionistic personality taken to the extreme. So my wife has a little bit of this. So as an example, she wanted to get the windows tinted. We had the tinting on our windows was just really bad. You know, it was probably put on when the house was built 15 years ago. We've lived in the house for 5 years, and we had all those hurricanes, and it's just wrinkly and just faded and just really ugly. So, guy comes, puts the new stuff on. Everything is fantastic. It's like, that's amazing the difference it makes. But you see, there's a tiny little dot right there. And that dot, I can't unsee the dot. That dot is driving me crazy. You've got to redo the entire window because of that dot. And everyone else is like, you can't even see that dot. Yes, you can see the dot right there. Yeah. Okay, yes, I see the dot. But who notices that dot?
Is that the OCD or the OCPD?
The OCPD. The dot is all I can notice. All I want is for you to do the window right. But you can do the window right 8 times, and that dot went away, but now there's 4 dots. I should have just left the window alone, but now I'm in too deep. Can you please redo the window a 5th time? Yeah, that's kind of how OCPD manifests. So when you're dealing with the contractor who doesn't have to live with you, it's one thing. But anyway, so if you ever read the Screw Tape Letters, Screw Tape talks about that. You guys know what the Screw Tape Letters are? Never. So the Screw Tape Letters are a book where there's a demon who's telling a junior demon how to tempt someone into sin the right way. And so he's like, if you can just convince her that no one can do things quite right and that she's reasonable and just asking for it done right, then she'll drive everyone crazy and she'll always be angry. And that's kind of what OCPD is.
So like when we had stuff like hung in my room, I like have a really hard time like if like we hung like a shelf and I like couldn't be okay with it until I made sure that it was like leveled and I saw the level. Would that be like OCPD?
That could be a symptom of OCPD. I don't know if that in and of itself would be OCPD.
I feel like that's
Yeah.
why I am.
Yeah, well, we have resources. We will send them to you and you can read it for yourself.
For your bipolar.
Yeah, sometimes it's more helpful to let your family members read it. And they're like, yes, that's you. But anyway, so just be aware there is a difference between those two things. We use SSRIs to treat OCD. We don't necessarily use anything to treat OCPD, although you could. I don't know. I don't know how you treat it. Next, we just need to talk briefly about the approach to treatment of phobias and anxiety in general. So drugs can help, but they don't help enough for everyone. So it's important that we understand that the way that we overcome anxieties and fears is to face them. So the whole idea of a safe space is actually counterproductive. So if you want to be able to overcome your fear of something, what do you have to do? You've got to face it. And in facing it, does the thing become less scary? Nope. You become less weak. So if you're a weakling who can't face your fear, then you're always going to be overwhelmed by it. But when you realize that you're stronger than your fear, that's when you can overcome it. So as an example, if someone's got a phobia of going in public places, maybe they've got a really legitimate fear. If I go out, and this is like an actual person, if I go out in a public place, there's a chance that I might touch something and get some sort of weird disease and bring it back and my family dies. Does that happen in places in the world? Sure, Ebola, right? Is it likely to happen in New York City? Nah, not really. Is it possible it could occur? Yeah. So is it?
Yeah, it's nasty.
Now, how many people do you know in New York City brought home a disease that killed their entire family?
No one. Sorry.
Yeah. I mean, it is a reasonable fear in that it could happen.
Yeah.
But it's not a reasonable fear in that you should never leave your house because of it. But the question is, at what point in those two extremes do you draw the line at reasonable?
Isn't that like in Martin County how they have the hefe spreading so no one like went out to eat Thursday?
Right. Yes. Yes.
Well, now it's here, so I'm not going anywhere to eat.
Yeah. And for years I've been warning you guys that hepatitis A was coming, but hey, whatever. So the bottom line is, for that person who's afraid of going out, sometimes they can't even look at the elevator. Say they're in an apartment and there's an elevator to get down to the ground floor. They can't even look at the elevator because it's too scary. So what do you have them do? You have them open the door to their apartment and look at the... Okay, I'm just going to stare at it. You're watching it because like it's a monster. It could eat me. And then after like an hour of watching it, you realize it's kind of boring. So what's the next step? Take a step out of your door and watch it. Now it's scarier because I'm not in the safety of my own home anymore. I'm out in the hallway. And then eventually you realize it's probably not going to eat me. I'm strong enough to handle this. And so then you get a step closer. And then eventually you touch it. And then eventually you stand in it. Eventually you go downstairs and you go out for the first time in 10 years. And then what happens is you go home and you have an argument with your spouse. Why? Because you realized you're strong enough to face the fear of the elevator and go downstairs and face that fear. There's other things you might be strong enough to do too. And you've never told your spouse that you really didn't like that habit they do because you're too afraid. So once you become stronger in one thing, you become stronger in other things too. And it can dramatically change a person's life. So, well, that is desensitization, yes. Yeah. It's called aversion therapy. So you immerse yourself in what you're afraid of. But the key for immersion therapy to work, or aversion therapy to work, you know what you have to do? You have to choose it. If someone says, you're going to face your fear, take your face and look at that elevator, is it going to work? No, it's not going to work. Why? Because the person's not choosing it. In order for it to work, the person has to choose it. So that goes back to this whole FYE thing we talked about earlier with the depression screening, is if a person doesn't choose to go ask for help, they won't be helped. If someone for whatever reason they get caught, oh crap, I got caught trying to commit suicide. Now I got to go to stupid therapy. Is this stupid therapy going to work? No, why not? Because they're not choosing it. The person has to want to be helped in order for help to work. Does that make sense? So a lot of what we do in healthcare, one is screening and identifying, but then the second is educating a person as to the steps they need to do in order to get help. And what is the most important thing they have to do to get help with anxiety or depression? Is to choose to want help. Does that make sense? Okay. All right. Any questions about anxiety? Yes. Yeah. And so I don't know about the OCPD, but for phobias and OCD, SSRIs and SNRIs are commonly used. And for PTSD as well, sorry. I mentioned that earlier, I just didn't write it down. So for all of those things, you can use SSRIs. Now, one thing to mention about PTSD. The way that PTSD manifests in movies is nothing like how real PTSD works. So in the movie, it's like, there's a loud bang, and like, wake up the gun, and you're like, yeah, it's not. So really, PTSD is overwhelming emotions that are triggered by events that remind them of something. PTSD is often the result of experiencing what a person would consider evil. And a lot of times, it's something that they themselves have done, which is why it's quite common in combat veterans. It's not that they saw evil per se, it's that they were part of the evil they saw. It's partly why drone pilots are committing suicide at such a high rate, because it's just pictures on a screen, but they still know that they've killed people who they don't know, and it might have been the wrong person, and that guilt triggers PTSD in them. So PTSD can be a result of things happening to you as well as things you do yourself. So I listened to a decent amount of Jordan Peterson, and he talks about a client that he had who was a girl who had been told by her parents all her life that people are angels. Then she dated a guy who was a bit disagreeable, And when she disagreed with him with something, he actually tried to hurt her, like beat her up. And the look on his face as he was trying to beat her up, I think did beat her up, was so horrifying to her that that's what caused her PTSD. So it was that experience of, she didn't know that people were capable of harming other people, let alone feeling like they wanted to harm someone else. And so when she saw someone trying to harm her, that's what triggered it. Does that make sense? So PTSD is typically a person just can't handle the emotions that exist, and you might never even notice that they have it because they just kind of sit there and do nothing. But they're unable to do their daily activities, they're unable to live their lives like normal because of that overwhelming emotion. So most of the time, you won't notice that a person has PTSD because it doesn't look anything like it does in the movies. Does that make sense? All right, any questions about PTSD? All right. I think next we have not dementia, but psychosis. Yeah. If you're looking at the old slides, you're going to be missing a few slides. That's okay, because I'm pretty sure they are in the voice thread. So when it comes to psychosis, psychosis is loss of touch with reality, and it takes two major forms. So the first form is perception, and that's going to be manifested by perceiving things that aren't there, or maybe not perceiving things that are there. What's the name for that? Hallucinations. What is the most common form of hallucinations? Auditory, hearing things that aren't there. How many of you ever hear your phone ring and it's not actually ringing? Now, one of the things that we want to ask anytime a person has hallucinations is what type they are, and if they're voices, what's the next follow-up question? What are they saying? Are they telling you to do things? So command voices are particularly dangerous because they can tell a person to do something that they shouldn't do in terms of impulsivity. And we're not just talking about hurting themselves or someone else, but just things that a person shouldn't do. Sell their car, for like $5. Shouldn't do that. So anyway, you want to ask about command voices. Are they being told to do something? And then the next one is delusions, The next one is cognitive, which is thoughts. And thoughts can take two forms. One is, I guess they're both delusions. Delusions is when you don't think of yourself the way you ought to, or you don't think of the world the way you ought to. And that can be delusions of grandeur. So you get people who are like, well, I'm Gandhi, I'm God, and they make up famous person. The other one is paranoia. Now, remember this. You're not paranoid if they really are out to get you. But paranoia is when someone feels like they're being persecuted or watched or hunted in some way, persecuted in some way. One of the interesting things is that oftentimes patients in acute psych, they are being watched. They're watching me. Yeah, I'm watching you. But anyway, so paranoia and delusions primarily of grandeur. So quick little story. When my mom was in the Army, she was a nurse back in the 70s, and she was stationed in Thailand. And that was where they had the hospitals where if you were, once you were stable enough to be discharged from Vietnam, they sent you to Thailand in order to fully recover. And there's a pretty big psych ward there in the Thailand Army hospital. And so there was this little guy, I think he was Hispanic, and he said that he was Jesus. Sorry, no, he's God. He's like, and he told everyone that met him he was God. And then one day they got this new guy came in, and he was like this enormous black guy, just, Michael Duncan Clark big from Green Mile. And he's, I'm God. And so everyone's like, what is going to happen when these two gods meet each other? So the little guy takes one look at the big guy and says, I'm Jesus, God's son. So apparently there's limits to the delusion. But hey. So sometimes what happens to a person will feed into their delusions. So you can have psychosis in, the main disease that's associated with psychosis is schizophrenia, but you can have psychosis in other disorders as well. So you can have it in bipolar in extreme cases. You can also have it in depression in extreme cases. So remember we talked about if a person has depression with psychosis, so either hallucinations or delusions or paranoia, you might use an antipsychotic for that person because they're experiencing psychosis. So there was a guy who had bipolar disorder, and he thought that he was Jesus. And so what happened to Jesus when he went on the cross? Well, yeah, but they put nails in his hands, right? So he's like, well, he took scissors and he stabbed himself in both hands, and then he stabbed himself in the heart. Now, what did they do to make sure Jesus was dead? They pierced his side. Well, when you stick yourself with scissors in the chest, what could that cause? Going back to Pathopharm 1. What happens when you pierce the pleura? What about your lungs? Collapse? What's that called? Pneumothorax. What's the treatment for a pneumothorax? A chest tube. So they stick him in the side with the chest tube, and that feeds into his delusions. He's like, just like Jesus, they pierced my side. He's like, you see, I really am Jesus. So, yeah. So people's delusions can be malleable, and they can change their delusion to fit the situation. But anyway.
What's the difference of psychosis with extreme OCD?
Well, if a person has OCD and they're having one of these three things, then they would be psychotic in their OCD. When we use the word psychotic, by the way, we don't mean like want to kill you. That's an Americanism. When we say psychotic in the clinical sense, we mean having one of these three symptoms. So if they have those three symptoms, then they'd be psychotic. If a person has a psychotic break, it means that they're experiencing one or more of these three things. Does that make sense? Okay. All right. So the way that we treat delusions is primarily with drugs, and we've got typical antipsychotics. These are the old drugs. And the way that they work is by inhibiting or blocking dopamine receptors. So dopamine receptor blockers or antagonists. Now the problem with dopamine receptor antagonists, well, there's quite a lot of them. And with the old atypicals, they had an enormous number of problems. So the first thing is, dopamine is an inhibitory neuron. The way that you move is you have excitatory neurons causing acetylcholine to cause the muscle to contract, right? And then dopamine in your brain is coordinating with the other muscles to relax. So if you want to feed yourself, you want to take food in this hand and bring it to your mouth, what do you have to do with this muscle right here? Contract it. What do you have to do with this muscle right here? You have to relax it. Now, keep this muscle as tight as you can and bring your hand to your mouth. What happens? It's like you get shaky and it's hard, right? There's like muscle rigidity. So when you block dopamine receptors, patients can get tremor and muscle rigidity. And that's caused by an imbalance of acetylcholine to dopamine. And that is called Pseudo Parkinsonism, because Parkinson's disease is caused by loss of dopamine neurons. Tremor and muscle rigidity. And that's called Pseudo Parkinsonism. Yeah, Pseudo Parkinsonism. Yeah. What? Yes, those two things together are called Pseudo Parkinsonism. The other thing that can happen with that is, the other thing you can do about that is you can give them an anticholinergic drug. So by blocking acetylcholine in the brain, you're going to bring the dopamine and acetylcholine kind of back into balance. And the drug that you would use for that, so the drug that we use to treat the pseudo-Parkinsonism is called benztropine. It's an anticholinergic. And if you think about it for a moment, what's the first anticholinergic we learned? Atropine. And what's this? Benztropine. And what's it used for? To treat the pseudo-Parkinsonism, which is defined as the muscle tremor and rigidity. And the brand name is Cogentin, which it means like cogent is like thinking. So it's like makes you think better, except it doesn't actually make you think better. It treats pseudo-Parkinsonism. Don't ask me why.
So I was thinking of it. Pseudo-Parkinsonism is a
Adverse effect. Yeah. So we treat the hallucinations, delusions, paranoia with a typical antipsychotic, which blocks dopamine receptors. As an adverse effect, the first one is pseudo-Parkinsonism. Yeah. Can also cause drowsiness, and dry mouth, and other anticholinergic effects. In a lot of ways, it's kind of like taking Benadryl. So Benadryl causes drowsiness, dry mouth, and a bunch of other adverse effects. And these drugs can also. How many have ever taken the drug Phenergan? It's an anti-nausea medication. No one? No. All right. Well, Phenergan is actually a typical antipsychotic that turned out not to be very good as an antipsychotic. One of the things that these drugs can also do is they reduce nausea. So some of them are also used as anti-nausea medications short term. And that's how we came up with Phenergan or promethazine. All right, so the pseudo-Parkinsonism, the drowsiness, dry mouth, other anticholinergic adverse effects, decreased nausea, although I guess technically that would not be an adverse effect, just an other effect. And then we get to the really important ones, tardive dyskinesia. So tardive, refers to repetitiveness, dys meaning bad, and then kinesia, movement. So these are typically repetitive movements that a patient can't stop doing. So one of them is chewing motions. Another one would be lip smacking. And patients can't stop doing them. How many of you are the kind of person where, like, if you're sitting down, you start shaking your leg? And you can't stop. Someone points it out, and you're like, oh, yeah. You're like, stop. Okay. And you go right back to it. So it's kind of like that. They can't stop doing those motions. They can be incredible. Some patients don't notice, and for other patients, they're incredibly distressing. You know, it really bothers them that they can't stop doing those motions. And then one of the potential problems is that when you take the patient off the drug, they keep the tardive dyskinesias forever. So the tardive dyskinesias can become permanent in some cases. And then it's not exactly tardive dyskinesia, but it's related. is called akathisia, and it's rocking. So a person will just kind of like sit in a chair and rock like this, and you're like, stop rocking. I'm not rocking. What are you talking about? And sometimes they're aware of it and it bothers them. But that rocking motion is called akathisia.
And if it doesn't go away, there's no way to get it.
Sometimes it'll fade over time, but sometimes it doesn't. So potentially permanent adverse effect. I don't know.
You know what I'm talking about? Like, I know people who are all like this, like jittery. Yeah.
I don't know if that's what it is or not.
Okay. Does this
Little bird-like?
like having too much of the drug, or just like some people are more prone to it?
The longer you're on the drug, well, the longer you're on the drug isn't necessarily a predictor, but the higher the dose it is. Some patients will experience tardive dyskinesias within a couple weeks. Some will experience them after a couple years, and some people will never experience them. So it's just individual. We don't know if it's related to the metabolism or something else, but that's what it is.
So does it have to or not? Like I had one guy that was schizo and he just played with his belly button non-stop. Like literally, he didn't even know what he was doing. So like aggressive. And we were is that the same thing or is it
Probably.
your mouth?
They're very commonly related to mouth, but I guess not always. All right, so when we use typical, names. So the first one that you need to know is thorazine, which is, I think, chlorpromazine. Is that right? It's on your thing. Everyone just calls it thorazine. So the very first one that was ever invented is thorazine. And the one that's most commonly used nowadays is haloperidol or Haldol. Quetiapine. Yeah. And then, quetiapine is a newer one, but it's also considered typical. So it's becoming more common. When we use these drugs to treat a patient who has schizophrenia, it's going to treat their positive symptoms. So the psychosis symptoms themselves are called positive symptoms. These are things that should not be there, but they're there. They're positive for hallucinations, delusions, or paranoia. Does that make sense? So the antipsychotic drug will hopefully make these things disappear. But what's the problem? Is it makes other things disappear too. Things we don't necessarily want a person to have disappeared, like normal communication, like will. What do I mean by will? Desire, drive to do something. And then also pleasure. We already told you the fancy name for loss of pleasure. What is it? Anhedonia. When the person loses some of their communication ability, we call it laconia. There was a place back in ancient Greece and ancient Roman times called Laconia, and they were very notorious for not saying very much. So they would try and use as few words as possible to communicate, I guess because I don't know why, but they just didn't like to use a lot of words. So if you've ever heard the very famous, when Julius Caesar conquered the Carthage, he sent back a message that was just 3 words, Veni, Vidi, Vinci. I came, I saw, I conquered. So that is an example of what's called a laconic message, because it's as few words as possible to get across the message. So it's kind of like talking to a teenager. So you ask a teenager, how was your day? Fine. What'd you do? Nothing. What'd you enjoy? Nothing. So nothing at all was fun? Nope. Your teacher didn't talk to you about anything? Nope. So that's an example of kind of like teenagers with their parents tend to be laconic. They don't say that much. So when you experience a patient who's like that, this is called a negative symptom. They should communicate, but they don't. It's negative. They should have pleasure in things they do, but they don't. The pleasure is missing. What's that called? Negative symptom. A person should have the will to do things, but they don't. So I'm trying to remember, I'm missing what that's called. So sad. Well, that's what happens when you get old. You lose words. Don't get old. I'll remember it like as soon as we get out of class. So anyway, these are called negative symptoms, and they are typically as a result of adverse effects of the treatment. So positive symptoms are symptoms caused by the disease. They're things that shouldn't be there. Negative symptoms are things a patient is missing, and they're usually an adverse effect of the medication. All right. So now let's talk about atypical. You just need to know that it's the first one. It's still used, but it's not as commonly used as Haldol. They categorize the different antipsychotics by strong and weak or strong and moderate, and Haldol is very, very strong. So it's more commonly used for acute patients where you need to try and control the symptoms quickly. But once a person is under control, they might shift them to a more moderate one because they don't necessarily need as strong a suppression all the time.
So for the Haldol, the adverse effects, is that a negative symptom, or is that just overall you're saying those are what negative symptoms are?
That's just what negative symptoms are. And I gave you 3 examples. No, tardive dyskinesia, negative doesn't mean bad. Negative means missing. So it's no. Tardive dyskinesia is an adverse effect of the medicine. And those negative symptoms, because we used to say that schizophrenia was characterized by positive symptoms and negative symptoms. And then we began to realize that the negative symptoms are often caused by, they're actually adverse effects of the drug. But because we called them that first, they're still classified as symptoms rather than as adverse effects. So technically, laconia is probably an adverse effect of the drug.
Like if you take Tardive, you start to lose your will. That's technically an adverse effect. We call it a negative effect because you lost it.
Yes. Yes. All right.
So you said you would probably give someone Haldol if they had something. So isn't it one that you want to start off low? You want to do the Haldol and then move on to whatever.
Well, not necessarily Thorazine, but a different one, yes. So in acute psych, they usually go with the strongest. It's also the most sedating. So you typically start out with Haldol. And then you might taper that down and then switch them to a different drug as you see what else is going on. But a patient who's acutely psychotic, you typically start them off with a very strong. And so there's actually a cocktail. Can't remember the third drug offhand, but it's usually they give them Benadryl and Haldol together, along with maybe Valium or lorazepam. But anyway, they give them that cocktail. It's like 3 drugs all at the same time to try and bring them down. And then once they've got them under control with, not like I've got to control you, but the patient feels under control, then you reduce the drugs and switch them out. Another issue with these drugs is that a lot of times patients will forget to take them, or they won't take them because they just don't feel like it. So what we're moving towards is what's called depot drugs or depot drugs. So a depot is when you put a large amount of supplies in a place and you leave them there. And so a depot drug is you leave a large amount of drug that gets absorbed slowly over time. So you give them an injection, and the injection lasts for, say, 3 months. That way they don't have to take a pill every day. Because what's someone who's lost touch with reality, how well are they with keeping a schedule of drugs? Yeah, not very. So that can help them to live a more normal life because they don't have to rely on something they do every day in order to be maintained on the medications. All right. So the next thing is the atypical antipsychotics. And atypical antipsychotics work the same way that typicals do. They block dopamine, but their blocking dopamine is much less. So they're not as strong. But they also do other things. So one of those other things, for example, one of those other things could be something like increasing or decreasing norepinephrine. And all of them are slightly different. So they can have other things going on besides the dopamine. Now, because their blocking of dopamine isn't as strong as the typicals, the risk of tardive dyskinesia is much, much lower. It can still occur, but the risk is much lower. So for patients who are not acutely ill, you're mostly going to see them on the atypical antipsychotics and less so on the original typical antipsychotics. For patients with bipolar, the atypical antipsychotics are very, very commonly used. And also quite commonly used for teenagers who have depression, because a lot of teenagers who have depression also turn out to have bipolar. All right, any questions about the atypicals? Oh, names. Yeah, there's like 5 of them you should know, and I'm always forgetting at least one of them. So why don't you read them out, and I'll write them on the board. I'll start you out with, well, I was going to, clozapine. Yeah, risperidone or Risperdal. Hold on. Risperidone, olanzapine. All right, what else you got? Say again? Quetiapine? And you got at least one more. Ziprasidone. All right, now which one of those is Abilify? Does it say the generics?
Yeah, but none of them are.
Oh, all right. Well, there's another one called Abilify. And so that goes back to, the naming of these drugs. Sometimes the names are very suggestive. I'd like to be on Abilify. I could use some more abilities. But anyway. So these drugs are commonly used in schizophrenia and bipolar, and then also teenage depression, because a lot of teenage depressed people also tend to have bipolar. And on that note, I guess we should move over to bipolar. What time is it? 3:30. Okay. Just enough time to do bipolar. How do you feel about that? All right, so we mentioned earlier that with depression, unipolar depression, if this is kind of like a baseline of normal, most people are going to go a little up, a little down. Maybe sometimes they go a lot, a bit more or a bit more down, but they're more or less around that normal. Then with unipolar depression, they're going to go down for sustained time and then back up. So they're spending a lot more time in down, but they never really go up above normal, not much above normal. With bipolar, you can be very, very down, but you can also be very, very up. And so this very, very up is what makes it, instead of unipolar, it's bipolar. It can go both directions. And this very, very up period is called mania. Now, if a person has, sometimes we call symptoms subclinical. What that means is the patient's got the symptoms, but they don't have them bad enough that someone has diagnosed them. So a person could have a little bit of mania, but it's enough to make them really fun to be around, but not quite enough for them to get flagged as bipolar. Does that make sense? So patients with mania typically are going to have very little sleep, lots of energy, very impulsive, And they are often fun. Kind of person who at 11 o'clock at night is like, hey, let's go. And you're like, okay. And you're sleepy and they're like, come on, let's go do the next thing. And they're really great to go have adventures with because they're always getting into new adventures. Kind of like living with Dory. The downside of this is they often don't take care of themselves very well. First of all, they're not getting enough sleep. Second of all, they might not be eating enough. Third, they might not be taking care of themselves in terms of hygiene and other things that a person should do on an ordinary basis. They might stop working because who wants to do boring work when you can do fun and exciting adventures? They'll often do very impulsive things with their money that can destroy the family finances. They'll buy a new car, buy a boat, buy a motorcycle, sell the home, if the home is only in their name, they might sell the home and not tell anyone. If you have a stay-at-home mom, dad might come home and the furniture is completely rearranged every day. Or you come home and there's all new furniture, and where did this come from? So that sort of thing can happen. So in hypomania is where there's just a little bit of mania. So hypo doesn't mean less than mania. Well, it means less than mania, but still way above normal. Does that make sense? Okay. So as far as treatment goes, you can use SSRIs, but sometimes SSRIs will make patients worse. So let's think about this. If you've got a patient who's very impulsive and you give them an SSRI, what's one of the adverse effects of an SSRI? Increased impulsivity. So it might make them feel better, but might make their mania worse. Sometimes it won't help their depression either, though. So if you have a patient who's very, very depressed and they're kind of atypical, they're not getting much sleep, they're got more energy than usual, but they've got all the other symptoms like normal, maybe they've got an appetite, maybe they don't. No appetite is also often associated with mania because who has time to eat? So all of that stuff is going on. They might actually be bipolar. And you put them on an SSRI and it doesn't work. Well, it's not that SSRIs don't work for them, it's that you're treating the wrong thing. So that's where that can work. In the severe cases, patients can become psychotic, and I mentioned that guy earlier who thought he was Jesus. So patients can be paranoid or have delusions of grandeur or have hallucinations that go along with being in a high manic state. You can also have those kinds of symptoms with depression as well. So as far as treatment goes, the number one treatment for bipolar disorder is going to be mood stabilizers. So the very first one is lithium carbonate. And I'm sure you've heard that you put bipolar patients on lithium. Have you ever heard that? I mean, everybody knows that from movies and TV shows, right? Maybe not. Maybe you watched the wrong TV shows. Anyway, so lithium can be used. The problem with lithium, well, there's a number of problems with lithium. One is it can damage the thyroid gland. So as a result, you need to do a thyroid screen before you start a patient on it, and you need to monitor thyroid as things go along. Second is that lithium and sodium and potassium to some degree are slightly interchangeable. So you need a good basic metabolic panel before you start them on the lithium. And then the final thing is that lithium can cause cardiac toxicity. So you want to get an EKG before you start them on lithium as well. And then monitor their heart rate and ECG over time. Once a patient gets lithium toxicity, they can really never go on lithium again. And so you can read a little bit in your book about lithium toxicity, because we don't have enough time to go into it. We've only got about 5 minutes left. So sad, I know. So lithium is the oldest one, but it's really not used as much anymore. What's more common nowadays is to use anti-seizure medications. And there's several of them that can be used. The most common one is probably called Depakote. The generic name is valproic acid, and very commonly used in kids for bipolar disorder. Another one is lamotrigine, which is also known as Lamictal. Lamotrigine or Lamictal is a sulfa drug, and it can result in Stevens-Johnson syndrome. A few years ago, we had a student, not a nursing student, but just a student here on campus, who was bipolar, and when she was 16 years old, her Lamictal caused her to have Stevens-Johnson syndrome, and she went into renal failure and all sorts of things, still dealing with the fallout of that, as a 22-year-old college student. Lamotrigine or Lamictal. It's an anti-seizure drug. So another one would be Tegretol or carbamazepine. There's a newer version of it, which is the active metabolite, which is oxcarbazepine. I don't remember the brand name on that one offhand. So all of those anti-seizure drugs are commonly used as mood stabilizers. And then the last thing is using atypical antipsychotics, sometimes in combination with an SSRI for patients who have bipolar disorder. Bipolar disorder is one of those things that can be really tricky because we're not always looking for it. So if you have a patient who is depressed, drinking alcohol, because they're often self-medicating with alcohol, they also have insomnia. Maybe they stay up until 5 in the morning every day. They also have anxiety. And they also have ADD or ADHD. Yep. If you have a person who's depressed and they also have all of those other things, they really need to be screened for bipolar, because there's a very good chance that this isn't just depression, it's bipolar depression. And so they try them on SSRIs and it doesn't work. It makes them worse. They really need to be screened for bipolar. And I'm actually thinking of 2 people at the moment that I can think of right now that I've known here at PBA who this would fit for. I don't know if they're bipolar or not, but I've told them that they need to go get screened for it. I don't know if they did. Because they're not my patient. They're just people I know. Yeah, they've got all of that. Patients with bipolar disorder a lot of times will be doing drugs and or alcohol to try and self-medicate because they know something is wrong and they're trying to fix it. The problem is that it doesn't fix it. All right, on that note, we are done with psych. Whew. So next class, we are going to be talking about other central nervous system disorders. So we'll be talking about Alzheimer's disease, Parkinson's disease, strokes, and all of that kind of stuff. Ideally, we'll get through all of it next class, and then we'll be able to do genetics and HIV the following class.
And then that's everything on test one.
And then that's everything for test 1.